spend most of my time these days in Africa with educating entrepreneurs. And Peter Drucker, one of the management gurus, years ago said, behind every global social and environmental issue is a business opportunity in disguise. And I always like that because for companies, for the private sector, the more, and for NGOs, the more pain that is experienced on the ground means that there's an opportunity to do something about that. For the private sector, it may be profit motivated. For the NGO, it may be mission oriented. But the fact that we have so much pain in this tells me that there's huge opportunities for innovation, huge opportunities for, and we see a lot of examples of that. Now let me turn to you. So you're in a very different situation in China. In fact, you're all over China. You spend most of your time traveling throughout China. And you've done some very interesting work around children with AIDS, etc. So could you tell us about the specific project, and then tell us a little bit about how we should think about healthcare in China generally?
We started the foundation with HIV-related causes. So in the past 20 years, we have cumulatively supported 21,000 children, mostly with education, but at the same time psychosocial support. And these 21,000 families are HIV impacted. Either someone has died of AIDS or is still living with HIV. So it has a lot to do with medical treatment, but at the same time, also dealing with the social stigma from neighbors, from kids. But going back to the original question, can healthcare be both good and inclusive? I believe so. But the problem is, if it is good and inclusive, can it be affordable? Affordable to the government and affordable to the people. I think what I can say is that it can be inclusive and better for relatively less money. Let me give you an example. When China started to provide the free antiretroviral treatment for HIV patients in China, that takes care of the inclusivity, so everyone is included. Everyone can get free treatment. But at the same time, there are many problems. One of the measurable issue is the adherence. Because many of them are in poor areas, they are not properly educated about the importance of adherence. So sometimes they don't take the drugs regularly, or sometimes because of side effects, they stopped, and it creates a lot of drug resistance. So you have the money and the political will to provide free treatment, but it is not properly done, and a lot of people still become sick or develop drug resistance. So I, at that time, happened to come across a model in Haiti, which mobilized the neighbors in a poor resource setting areas to monitor the HIV positive people to take the medicines visually. So it is called direct observation therapy. You literally go to see and watch that person taking the drugs on time. So it seems very primitive, but it is also very effective. In China, we mobilized, these are very high prevalence areas. So in one village, we might have 300 people living with HIV in a village of 2,000. So it's very condensed area, because in that part of China, a lot of poor peasants sold blood to make a living for many years, and due to unsanitary blood collection practices, they contracted HIV and many were dying. So we mobilized the neighbors. Many of the neighbors themselves are also living with HIV, to go around the block, and we assign 5 to 10 patients to each of these DOT workers to every morning when it's time to take medicine, really to see them taking the medicine, carrying a pot of hot water, and with a lot of encouragement. Knock knock, who's there? Oh, I'm your neighbor. I'm here to watch you take the medicine. And then after that, you say, oh, you look much better today. Keep going. Don't give up. You'll be much better. This kind of community-based model is very cost-effective. We spend $1 or $2 to each of these DOT workers who are mostly housewives, just doing, going around the block every morning to see their neighbors, and it's a simple job, and then they each one to take care of 5 to 10 people, and then for $2 a month. So we only use marginally, we increase the total cost only a little bit more, but actually the adherence becomes significantly better. So, and afterwards, the health minister at that time happened to be around the area, and someone reported the program to her, and she thought, oh, this is a good idea, we should scale it up. And overnight, our program in one village has become the national model, and at the peak of its time, the government employed over 2,000 DOT workers all over China to do this. Because from China's perspective, they have spent so much money on providing free treatment, but the performance is still not there. But by spending a little bit more, they can significantly increase the performance, the adherence. So they are much willing to do that, but sometimes they just don't know how to do it. And I think the trick also is to give some incentive to the people who are willing to be observed. And in that case, we give chicken eggs. If you allow us to observe you take the medicine, for every 2 weeks, we will provide you with 2 kilograms of chicken eggs. So I have chicken eggs. Yeah, it also, we don't want to give money we give money to the worker, the observer, but we don't want to give money to those who are being observed. So we give chicken eggs also, it would increase their nutrition level, and for that, I think they are more willing to be observed. And I got a nickname in that part of China related to chicken eggs afterwards.
Can you tell us what that is?
Just a guy, the chicken egg guy.
Chicken egg. Very good. So you could maybe give us a little insight. We have Bangladesh, we have the Philippines, which are more traditional capitalism models, and yet you're operating within a state capitalism model. Do you think one has more advantage than the other in terms of trying to address these issues of inclusiveness in healthcare? Anything you could say or would like to say about that?
In China, actually, there are 4 main conglomerates doing private healthcare. Unfortunately, they are very profit-driven, and sometimes the quality may not be something that you spend more money, but doesn't mean that you get better quality. And I think there is a space between the two that we use a more social enterprise model that it can be profitable, but at the same time higher quality and more social minded.
So let's come back to this issue of this gap between where we'd like to see things in terms of affordability, in terms of accessibility, and the lack of inclusiveness. What's at the heart of this? How do we need to think about this gap, and what can we do about it?
I want to step back a little bit. Okay. Inclusive healthcare will only come when people believe that they will be cured. And you can only do that provided you can serve with quality. So it's like a catch-22 situation. You have to give good quality services, then people will start believing they can be cured. When they believe they can be cured, then their health-seeking behavior changes and they start demanding services. And then again, the quality has to. So that is extremely important for sustainability to happen, for qualitativeness to come in. So you can do awareness. 5 million people can be aware of something, but if they see one cure, it works better. So that's one. Second, I think healthcare is beyond just medical care. And that we have to accept, that especially for remote areas, for lower ends, for the ultra poor. If you only give healthcare, it's just not enough. If you don't have enough to eat, if you haven't got your EPI or your injections, if you have not, if your child is not going to school, you don't see a future, you have a traumatic situation, so when you have a flood or you have a cyclone, then you're again back to square one. So the whole ecosystem has to improve. So we need to look at that, also to improve that when you're thinking of inclusive healthcare. And this is what Friendship tries to do. So in health now we are serving about 250,000 people a month, but with all the other sectors that we've got, education, inclusive citizenship, climate change and adaptation, which is disaster management, etc., etc. So we are serving about 500,000-600,000 people a month. Now, the whole area needs to come up in the rung of socio-economics before we can say that healthcare is actually working well, or that people can actually buy sustainable healthcare here. So we have to work with the socio-economic conditions and healthcare to be able to provide that platform for sustainability. And that's what Friendship as a whole tries to do. So coming back to what you asked about how we see
Close the gap.
how we can close the gap, we need to first identify the gaps properly. I think this is key to any innovation, key to any success of any system that you put in. I'll give you a little story. So there was this, I don't know if you're aware, EPI, which is the child immunization. Bangladesh government has got a 72% or something like that, which is very high and very good. In the cities you have, 80% of children getting immunized. In the areas we are working, which is more than 10 million people, we identified the gap as being less than 5%. So it was impossible to convince UNICEF, to convince the government that we needed to have a different kind of a system there. And all they needed was access and to ensure that the people in these areas would come together when the government was bringing in the EPI injections. So when we closed this gap, within a year, the EPI rates in that area went up from 5% to 98.4% within 1 year. So it's identifying the gaps very practically without bringing in your own ideas, but actually listening to people and observing. So I think it's extremely important that to close the gap, you need to ensure that you've identified the real issues and you've listened to the people carefully and be humble enough to know that that what you have brought in might not be the right solution, but it's something else.
How do we listen to it?
Absolutely.
Yeah. Well, you bring up so many interesting points here, and one of them that I certainly resonate with is and I think, Paolo, you hinted at this in your opening remarks, about how these are all connected, how all these issues are connected, and to try and solve one issue without the others. For someone who has, we can restore the health but has no job, is still a real problem. Well, any thoughts about, again, closing this gap? How do we address this integrated, some challenge?
No, thanks, Brad. And let me go back to your earlier question to Runa as well on what's behind the, the issues in terms of access and affordability. I think recognizing that healthcare is very different in different parts of the world. I think you can point to 3 or 4 different things that drive this inequity in terms of access and affordability, right? Number one, just in terms of demographics, you have a growing population, right? More complex conditions in many cases, new diseases that we just have to manage as a group of practitioners. Second is, I guess we have to realize that healthcare is also subject to fundamental market forces of supply and demand. Right? You don't have enough doctors, you don't have enough pharmacists, number of hospital beds, etc. And then the third is the role of the private sector versus the public sector, which varies greatly across different countries. There are countries where the public sector's role in healthcare is extremely deep and fast. Take the UK, for instance, right, or Canada. There are countries where the private sector takes an extremely proactive role, in fact, a dominant role. Take the US. It's sort of a balance, and you see a lot of, gaps in the system. And so I think those 3 things help push this issue of accessibility and affordability that unfortunately leaves us all with gaps to fill. Which then, to your second question, Brad, is how do you look at it? There's no one set way, right? I guess for us, and we were talking as a group earlier, we're talking about inclusive innovation, right? How do you serve the underserved, or how do you serve more people with sustainable business models? And it's hard, and if there's anything that I can just share with the audience, one thing that we've learned at Ayala as we got into healthcare is it's almost like you have to look at things upside down. Look at the problem that you're trying to solve, and then try to develop a business model that can operate against that. So for instance, in primary care, 3 years ago, tons of research that we did in the space, interviewing hundreds, thousands of consumers, doctors, whether it's one-on-one interviews or focus groups, to try to understand what are the needs, basic needs of the Filipino middle-income patient and a Filipino middle-income family as it relates to primary care. And we heard loud and clear that patients, families did not go to a primary care physician. They preferred to self-medicate, or if not, just completely ignore their condition for a variety of reasons. But first and foremost was lack of access. It's so hard to get to a quality facility, either because of traffic or either because they're just too far away. Two, in many cases, if it's a public hospital, it's a long line to get access to just basic primary care. Or if it's a private hospital, you end up paying a lot if you decide to go to the emergency room. So we heard that loud and clear, and so we said there must be an opportunity for a primary care model that's retail and that's community-based. But then we asked, how much would you be willing to pay? And I remember the analysis that we did at that time, fairly sophisticated, conjoint analysis, things that we learned at school, right? And you find out that people are willing to pay X, right? Which is not a lot. They were willing to pay, which is a sign of a growing middle-income society, but that wasn't a lot. And the challenge for us from an innovation perspective was, how do you then build a business model that can hit that price point? So it's not, I guess, the traditional way of coming up with a business is, what's a nice, cool idea that I can launch, right? And then how much will that cost? And then hence, how much do I price relative to that cost? In this case, you have to determine the price first and the demand, and then figure out a model that supports it. And I guess that's one learning I can impart on others is, as we think about solving problems in healthcare, which is vast and very diversified, and just a lot, but if you pick certain problems that you want to fix, look at it from a consumer perspective, from a patient-first perspective, understand what people are willing to pay for, and then build around that need. That's probably the best way to approach it.
Well, again,